Hi, good afternoon. I'm Al Richmond, Executive Director of Community Campus Partnerships for Health. I'm delighted to be with you this year for your 2021 Community Engaged Scholarship Forum. It's such a delight to be here with you. I wish I was with you in person, but it's even more intimate because you're with me in my living room. And so for the next 15, 20 minutes, I'll share with you some highlights about Community Campus Partnerships for Health and our work in advancing equity and social justice. Next slide. The mission of Community Campus Partnerships for Health, or CCPH, is to promote health equity and social justice through partnerships between communities and academic institutions. This also includes anchor institutions, faith-based organizations, businesses, philanthropy, and other groups that are committed to the advancing of social justice and equity. Partnerships is in our name. It's who we are. It's what we do. It's what we believe in. And what I say to people is each day, through the myriad of partnerships that we have, we're living that out. We believe that authentic partnerships facilitate social justice and health equity, and that without authentic partnerships, the operative word being authentic partnerships, we will not be able to actually advance and achieve social justice and health equity. So it's really about authentic partnerships. I would like for you to take a minute and look at this particular slide. Start by looking at the bottom section of the slide. This is a visual image that many of you have seen before, and you may be even familiar with it. I'd like for you just to take a minute there, and what you see in the lower section is around equality. And what you will notice is that everyone has a bicycle. They've all been given the same size bicycle, same color, same ornamentation, all of that. So everybody has a bicycle. That's equality. If you look in the top section, you see that people have been given a bicycle, but the bicycle is based on their need, their size, and their abilities. And this is what we call equity, such that when we talk about health equity, what we're really talking about is providing people with what they need, as opposed to equality of just giving everybody an equal access, because we recognize that different people need different things. Next slide. So when we think about health equity, Dr. Kamara Jones, former president of the American Public Health Association, offers this insight into health equity. It is, first of all, the assurance of conditions for optimal health for all people, operative word being all people. What does health equity require? Dr. Jones suggests that health equity requires 4 critical elements. Number 1, equal value of all individuals and populations, that we remove from our work a hierarchy and hierarchical structures that values or advantages some groups over the other. The second requirement is a recognition and rectification of historical injustices. It's one thing to acknowledge historical injustices. It's totally different to be intentional about addressing and rectifying those historical injustices. The third element or requirement is a provision of resources according to need. This is about equity. So think about the previous slide where people were provided with a bicycle, but it was based on their need. So it's the provision of resources based on need, not just providing everyone with the same. And finally, it's a fundamental shift in how we think about those at the margins. I always ask myself when people think and talk about underrepresented or marginalized people, who marginalized them? Who placed them on the parameters? So it's really about centering those who are on the margins. And finally, Dr. Jones recognizes that the elimination of health disparities will occur when health equity is achieved. So there's a direct correlation between the two. As health equity increases, health disparities decrease. Next slide. This slide, again, one that you're familiar with, is an iceberg. And what it highlights is that oftentimes in the healthcare setting, healthcare delivery, health access system, health education, we oftentimes focus on those things that are above the sea. And we think about people as being kind of what we see about them, CEE. But it's more than that. It's what's beneath the surface. Those things are less visible to us. And they include our values, the assumptions that people make about us, and even our own beliefs. But they also include things and factors such as our education, our income, our social status, our housing status, where we live, our zip code, our gender, our culture, all of these things that aren't always so visible to the naked eye, but they're critically important when we think about advancing health equity. What we don't see is actually more important than what we see. And oftentimes we make a lot of assumptions just simply based on what we see with our naked eye. Next slide. So when we think about social determinants, those things that are beneath the sea, my colleague Giselle Corby-Smith at UNC Chapel Hill, we talk a lot about an analogy around are we fixing fish or are we fixing the water that fish are in? And it's the water that the fish are in that's really the social determinants of health. It's those conditions in which people are born, grow, work, live, and age. It's all of those things, including the distribution of money and resources. The social determinants of health are mostly responsible for health inequities, and I'll show you that in a minute. Next slide. And this particular slide, when we think about an individual and we think about population health. And this pie chart allows us to kind of think about, as a result of this particular study, it acknowledges that in terms of population health, healthcare constitutes about 20% of what impacts population. 10% of it is around physical environment, 40% of it is around the socioeconomic factors, and 30% is around health behaviors. Next, just click. But interesting enough, it's in that 30% part of the pie that we focus most of our efforts around tobacco use, diet, exercise, alcohol use, all of those kinds of factors. And yet we're not accounting for the remaining 70% of these factors that really do daily impact population health. And so I think it requires a shift in our focus from the 30% on individual behavior, which really allows us to kind of blame individuals, as opposed to looking at the social determinants of health, the environments in which people live. Next slide. So the impact of racism on health is that we have to first define what racism is. Racism is a system of structuring opportunity and assigning value based on a social interpretation or a social construct. It was maybe about 15 years ago that I really understood that race is a social construct in every society, and that it is a system in terms of racism. And America has a problem globally. Actually, we have a problem with racism, not race. Racism is a system that unfairly disadvantages some individuals and unfairly advantages others simply based on how people look, how people present. But Dr. Jones makes this point in her work in calling racism a public health crisis, is that it also saps the strength of the whole society, and such that we should all be concerned about racism. Next slide. So the work of community campus partnerships for health has been centered in recent years around racism. In fact, dismantling structural inequalities and structural racism. 2 years ago, we were together with a number of colleagues from across the United States and New Orleans, where we were looking at how we address racism through the arts and how we dismantle racism through music, through dance, through theater, through the spoken word, all of that. This experience culminated in a visit to the Whitney plantation outside of New Orleans. I felt that it was critically important that people actually visit a place where people were enslaved in this nation, such that people could actually kind of get to the genesis of racism in America. And that was an amazing experience with people, many of whom had never stepped foot on the grounds, these sacred grounds where people, hundreds of thousands of people, had been enslaved in the US. And so we actually are moving forward with our work around understanding how we dismantle structural racism. Next slide. A crisis. Many people have asked me, what have we learned from COVID-19? And what I would say to people is that we've learned, for those of us who are in health disparities, that our greatest fears have come to reality. A crisis actually magnifies disparities and inequities. And in COVID-19, we've seen those kinds of disparities. We've seen those kinds of inequities. And I'll take a few minutes to kind of discuss some of that and challenge you to think about how these inequities are being manifested in your own communities as well. Next slide. This slide, unfortunately, is a little old. And that when we were pulling this together, we acknowledged the fact that over 500,000 Americans had died from COVID-19. 25 million total cases in the US. And what we have seen in the past almost year is that inequities have been amplified significantly as a result of COVID-19. Next slide. So one of the things that we began last year was a webinar series focused on communities in partnership, ensuring equity in the time of COVID-19. And we addressed a myriad of topics and issues around COVID-19 and how we collectively could address those inequities, including the incarceration, the mass incarceration of persons that actually puts them at greater risk for COVID-19. How America looks and treats people who we call essential workers, in particular farm workers in Florida and California. So these webinars can be found on our website at ccphealth.org. Find out more about what we're doing in partnership with our community to address COVID inequities. Next slide. So there are a number of factors that really have served to influence the systemic and structural factors that influence COVID-19 disproportionality. At the top of the list is actually just sheer racism. This could be the location or not locating testing sites or even vaccine centers in Black and brown communities, which to me is a very overt act of racism. But also this is about structural racism and historic racism that actually places some people at greater risk simply because of their social status, but also because of their race as well. Secondly, we've come to understand the impact of living conditions, that many Black and brown people, or those persons who are impacted disproportionately, are living in communities or in settings where they're at greater risk. Very dense communities, they're living in multi-generational housing, where when we say to people, you should actually social distance, that won't work for all people. People are living 5, 6, 8, 10 people in an apartment, in a small house, or even in a trailer. So the living conditions also place some people at greater risk than others. The work circumstances also places persons at disproportionately higher, more vulnerable to COVID-19 because they're what we call essential workers, and yet we're not treating them like essential workers. And such that one of the things that has really evolved is this whole idea of the risk divide in COVID-19. I was looking at work around from the Stanford Center on Poverty and Inequality, and it caught my attention where they were talking about the risk divide, that persons who are working face-to-face, like persons in the grocery stores and other settings, healthcare workers, are actually at greater risk, whereas those of us, and I'm included in that group, are able to work at home. In fact, I've worked at home now for almost 8 years. And so my exposure is actually less than it is for others who have to work each day face to face with the general public. And then finally, the underlying health conditions and the lower access to care that many people are experiencing and have experienced pre-COVID that now simply places them disproportionately at greater risk for COVID-19. These four factors are really critical that we take into consideration when we think about how this whole COVID-19 is playing out in the US. Next slide. So when we think about COVID, I wanted to highlight a couple of facts as well. The other term that I'm really embracing is the COVID economy. And the COVID economy really talks about that in this time where so many people have lost jobs, so many people are just barely living and barely holding on, so many people are facing eviction, that the world's richest billionaires, 10 of them, have seen a combined increase in wealth of $500 billion since the pandemic began. The truth is that some people are profiting off of COVID-19, and it's what we call the COVID economy. Counties with limited pharmacy access are at risk also of becoming vaccination deserts, leaving almost 50% of all counties in the US with hindered vaccination administration, not to mention the delay in having a coordinated national plan in the US to address COVID-19. Congregate settings, which include residential care communities, adult care facilities, and also jails and similar correctional facilities, have also resulted in high clustered cases of COVID-19. In North Carolina, where I live, at least 5 individuals who work in the North Carolina Correction Center have died from COVID-19. Think about that. And you will probably find that to be the same in Pennsylvania as well. And hospitalization rates and death rates per 10,000 respectively have actually placed more people at risk as well, when we've seen the disproportionality in terms of hospitalization rates and death rates between African Americans, the Black and Brown community as well. Next slide. So what can we do? I think this is the challenge that we have, and I will enter a time of dialogue and discussion with you. Next slide. So I really offer this model that we'll talk some about in terms of authentic partnerships that builds upon the recognition that every community has strengths and assets, and also works to address the needs and increase the capacity of all of our partners. Next slide. We previously, CCPH did some work with patients and stakeholder groups to understand what is it that patients or communities want through partnerships. And we found that there are 4 things, and I want to share these with you. Patients or communities want trust. Patients and communities require evidence of trustworthiness, which is different than trust. When we think about it, people do business with people they trust. People are willing to be vaccinated and be tested in communities and settings where there's a degree of trust and trustworthiness. And also, people want a system that is transparent, and they also want to be partners. So in this time of COVID-19, we need these 4 critical elements: trust, trustworthiness, transparency, and partnerships. This includes about testing, it includes about vaccinations, it includes everything associated with COVID-19. We can't leave out any of these. Next slide. So CCPH for a number of years has offered this model for authentic partnerships. It has 4 critical elements, and they are the guiding principles of partnership, quality processes, meaningful outcomes, and transformative experiences. I want to say a little bit about each one of these. Our guiding principles are 11 principles that can be found at our website, ccphealth.org. Quality processes really speaks to how we do the business of partnerships. It might include a memorandum of understanding or some similar kind of agreement. And then meaningful outcomes in terms of what's meaningful to both of the community, the academy, and other stakeholders. It's about creating win-win situations for everyone. And then finally, transformative experiences. How do we, in a time of COVID-19, facilitate and move towards transformative experiences for our communities? How do we harness the energy, the commitment, the power of communities to create transformative experiences, hence resulting in true, authentic partnerships? Thank you.
Al, thank you very much for that.
Hey, thanks, Paula.
That was a tremendous, although at lightning speed,
It felt like it too, right?
tremendous overview of health equity, and also what community partnerships should look like. Your use of the equality / equity graphic is one of my all-time favorites.
Yeah.
Just in terms of delineating those two terms and distinguishing them from each other, because people use them interchangeably and they are not interchangeable. So I appreciate that. And I also appreciated the overview of what authentic community partnerships should look like, because I think that's difficult for us here in the Academy. We're always looking at, a documentable outcome, and in a lot of cases, an outcome that can be recognized and appreciated by a funder, as opposed to an outcome that can be recognized and appreciated by the communities that we serve. I think that's very, very difficult. I think it's also difficult for us in the Academy to try to separate ourselves from our positionality as people who live in the United States of America, which has been historically and continues to be steeped in racism, and try to pull ourselves out of that so that we can really engage in authentic community partnerships that recognize the value in our communities. So tell me what you think a little bit about how we as academics can do that. There are those, of course, who are engaged in community engaged scholarship and community-based participatory research, and this is the work that they do. But there are an awful lot of folks who are just starting off on this journey who really want to be engaged. But I want to, we want to be sure that they're starting off on this journey appropriately.
Yeah. No, thank you, Paula. I mean, you raised so many great points, and I appreciate that kind of summary of my comments as well. I think that what really comes to mind as I was listening to you, I was just thinking about authenticity in all things, right? We have to be authentic with people. We talk about authentic partnerships, but you are right in that we have to be authentic about the conditions in which we live in America, but also globally, but we're focused now on America. We have to acknowledge the truth. The work that we've been doing around dismantling structural racism was not easy work. It's not easy work now because people are asking us, why are you doing this? What does that have to do? What does the enslavement of people have to do with where we are today? And what we say to people is that actually we continue to have the vestiges of the enslavement of people, right? And racism continues to linger. It is a critical issue in America. And if we don't address it, we really won't be able to achieve health equity. I'm excited about the fact that because I think people do want authentic partnerships and they want authenticity and they want truth and realness, that's where it starts, such that many young scholars, junior scholars, and seasoned ones as well are beginning to acknowledge racism as a critical issue in actually impeding health equity. We have to, that's why it's hard for me to talk about health equity and not talk about racism, right? I just don't think it's possible. I think the other point, Paula, is the fact that Um, People know more about bad partnerships than they do good partnerships. And so I offer our um, principles of partnership, quality processes, meaningful outcomes, and transformative experiences, and the principles of partnership as a framework that faculty academics can use to help them guide their work, but not only to guide the work of those in the academy, but also metrics that actually community partners can use to actually hold the academy accountable, right? So both groups can actually use the principles of partnership. And that's what we encourage people to do, is sit down and kind of work through that framework and see how they can work together and bring that together.
I think that's absolutely terrific, and that at least gives everyone an opportunity to start off with shared vocabulary
Mm-hmm.
and a shared structure.
Mm-hmm.
Something that we wrestle with all the time is that key principle in what you mentioned, what patients want, and that's transparency. And it's difficult, for institutions to break that desire to release some information, to hold some information. How do we encourage institutional leadership to really be transparent about what's going on within their institutions that has an impact on the community?
Yeah, I mean, right now, Paula, that's a great question, because what we are calling in the academy vaccine hesitancy is really based on the fact that people have a lot of concerns and fears about the vaccine itself. And so NIH, CDC, even the White House has to be transparent about the source of the vaccine. And there's been a real push towards really bringing the scientists out front, having them to talk about the fact that we just, the COVID-19 vaccine didn't just kind of fall out of the sky. It's
Right.
been work that we've been working on, scientists have been working on for a number of years. And that's important to really be transparent. But I think, Paul, because we weren't transparent about what scientists were doing 3 to 5 years ago, now they're like, what? When did that happen? Right. So transparency has to really guide our work. And leaders and administrators and leadership in higher ed have to be transparent about their vision for how they will work with the community, the science that's being done on their campus. What I encourage people to do is, like, I think every university should have a open house every year, maybe multiple times of the year, where the community neighbors just actually come on campus and they're able to walk through the buildings and visit the laboratories and visit the classrooms and really see what's happening on campus in what we call the ivory tower, right? We have to demystify the academy. We have to almost demystify scholarship and bring the community in into the academy and really help them to understand and see what's happening. In particular, for state institutions, I think this is a mandate, right? These are state dollars, these are federal dollars that are going into higher education. And so we absolutely need tremendous transparency there.
I think that not every researcher has the capacity to boil their work down to something that is obtainable by the entire community. I think that's a very unique skill, but I think it's something that has to be, again, a critical skill within the academy if we're going to engage the community. We have to be able to talk about what it is that we're doing in terms that are accessible to the community, so that we can take community reflections,
Right.
and everyone, again, as we said, can be on the same page. So democratizing what
Right.
we do in the academy is key.
Right. And I think it's about also just that, right? It is about democratizing what is occurring. And it's bringing people in. And it's actually also saying to them, and here's how we think you will benefit from our research. Billions of dollars right now are going into what I call the COVID economy. How do communities that are experiencing disproportionately from COVID-19 benefit from that? How do they benefit from the dollars that are generated by the University of Pittsburgh, right? How are, is the University of Pittsburgh actively engaged in hiring people from those same communities that are bearing the burden of, of the disease, but also are being researched on, right? So we have a lot of work. And I want to acknowledge also, Paula, that this is really about power. It's kind of, I want to go back to your first question is how do we do that? It's like it requires that we recognize that power is always at play in these community campus partnerships. And it's also what I call the golden rule, and that is he who has the gold makes the rules.
Absolutely.
So when the academy has the gold, they make the rules, and when you're on the community side, you're subject to that. So that's a power differential already that's at play. But always, and in every partnership, collaboration, or relationship, power is real. And when we operate from the standpoint that we're giving up something, if the academy thinks they're giving up something to the community, then they're less likely to be engaged authentically in that partnership because they see it as giving up something. They're giving up power. Well, no, what you're doing is sharing that, right? It's sharing. There's enough power and resources to go around.
I think there's something, the NIH just had a huge sort of town hall a few days ago talking about their stance on equity and justice and the way that they would like to reposition so that they are opening up the doors to diverse researchers, that they're, going to recognize community scholarship. But the funding structures that we're working under as well, that overhead goes to the institution. I don't know that I've necessarily seen a grant that says take that overhead, give it to the community, and then make this project work.
I haven't seen that either. I'm not saying I'm looking for it, but I haven't seen it.
So there are a lot of systemic structures that we have to break down in order to make that distribution of resources more equitable so that the community benefits not just from the outcome of whatever the scholarship might be, but the economic drivers as well.
Right. And for us as an organization, we're a small organization, but the things that we're doing is we're looking at who is, we are engaging companies, minority-owned companies and women-owned companies to work with in our communications, in the area of our communications. We're redesigning our website. We've hired an African-American company to do that. And so we are really committed to this. One of the things, Paula, that we wanted to do in 2020 was at our international conference. It was going to be in Flint, Michigan. And we had the desire to really make it as community centric as possible. So one of the things that we had envisioned was that we would have food trucks, local food vendors, where we would, everything would kind of like go back into the local community. We would have craftsmen and artisans from the local community to set up displays and sell their products in every space of our conference area. The goal would be that to not just to go into Flint and say, oh man, we feel so sorry for you because of the water crisis, but to actually leave money in that community, right? We had really designed an amazing event that unfortunately was canceled as a result of COVID-19. But that's the kind of model that I really am interested in. And this is the kind of thing, the new work, actually, Paula, of CCPH is really bringing together the intersectionality of scholarship and health and economic development, right? Because I personally believe, and our board supports me in this, is that the way out of health disparities is through uplifting people economically, right? Such that people have a living wage, they have health insurance, they have affordable housing and all of that. And then we can lift them up, right? And so I think this is what I'm talking about, is where we don't just see health as being the domain of the College of Medicine and the School of Public Health, but it's also about the School of Business and Finance and all the other disciplines on campus where we look at people holistically. That's what I was talking about when I was talking about that iceberg. It's the things that we can't see, the employment, the education, all
Mhm.
of that. That's what we have to focus on. I believe that we now have a moment where we can actually and kind of reset
Yeah.
things and right size some of this. I feel like what was occurring before COVID-19 was almost like the Titanic. And what I'm hoping that what we can do now is not just rearrange the deck chairs on the Titanic, but we can actually engage in structural and systemic change, because it's not will we have another pandemic? It's when will we have another pandemic? And what have we learned from COVID-19?
I agree wholeheartedly. And if we don't take those lessons away from this period that we are in right now,
Mhm.
we will have made a critical error in the way that we engage our communities,
Mhm.
and also the vision of universities as economic drivers in the area, and not just a place where people come to get
Mhm.
an education and then carry that education away with them.
Right.
So I agree wholeheartedly. I want to pause really quickly and let our viewers know that, please chime in with questions. We will take your questions from the chat, and we will talk about them as well. Um, I think one of the things that I wanted to talk about is the slide where you mentioned that only 30% of social determinants is behavior, and the other 70% are those socioeconomic status, physical environment, and healthcare, those systemic structures that determine whether and how people access healthcare. And I don't know that that is commonly known outside of community engagement as much, or it's not played up as much as it should be.
Mhm.
I did a
Mhm.
presentation for students a couple of Saturdays ago and made the same point, and they were absolutely floored.
Right.
Talked about redlining and showed them some of the redlining maps, and talked about being trapped in communities and
Mhm.
not being able to buy homes and generate wealth that you can then hold on to for future generations. We have to get that word out there, and make people more aware that it's not just a matter of behavior, but it is this entire systemic structure, racist systemic structure that we have put together in this
Right.
country.
Right. We have to get people in particular, at every point in every juncture of our educational system, understanding systemic and institutional racism and how it has continued, the contemporary manifestations like redlining. All of these redlining is, as an individual who has inherited property from my father, that property is in a historically Black neighborhood. The home that we own, that my family owns, is probably the value is almost $150,000 less than the same home in another neighborhood that's predominantly white.
Mhm.
That's the kind of discrepancies that we're seeing. And these are issues, Paula, that we've not really been talking about, right? On my bookshelf and all around me, I'm pulling up Richard Rothstein's book on the color of law, right? This is seminal reading, right? And there's others. When I look at the work of I shouldn't be doing this, right? I'm not getting any money from this cast. The origins of our discontent by Isabella Wilkerson. All
Yes.
of these kinds of we're seeing, I think, Paula, in this moment, scholarship is emerging around the area of inequities. And people are documenting that now for this generation to actually read and see the things that we've long known, kind of the anecdotal pieces, like we knew about these discrepancies as a
Right.
result of redlining, but now we have the evidence. And this is one of the things that I think that is so exciting is how can we use data to actually make the case. How can we drive policy by using data and presenting that to city councils, county commission, state and other elected officials, federal officials, and say, the evidence is in, it is clear. Redlining continues, and it results in a significant wealth gap between between African Americans and white Americans, right? It's not just about people's spending habits. That's what we've done is I think of it kind of like we kind of taken this Puritan approach to how we see everything. And it's like, it's all about the individual. It's like, if you just kind of pick yourself up by your bootstraps, if you work as hard as I work, you'll have the same thing. When you don't have it, it's because there's something wrong with you. So you're smoking, you're drinking, you're engaged in unprotected sex, all of these things. But your point is well taken. That's just 30%. What about the 70%? Those are the parts of me and you and individuals that healthcare systems generally don't think about. But I'm optimistic and hopeful. Even many healthcare systems are now not just doing a physical assessment, but they're also assessing patients around the social determinants of health. Are you employed? Do you have health insurance? When you leave here, can you afford your prescriptions? Are you even going? Where are you going when you leave here? Right? We're discharging people. We don't know that they have a place to live, right? And I remember a couple of years ago, I was talking to someone with one of the homeless coalitions, and she made me aware of this movement across the U.S. where in many cities they're building kind of housing environments for people who were homeless, who have been in a healthcare and acute system, so that they can actually go into a temporary housing situation, at least temporarily when they're discharged. So we're not just discharging these very sick and vulnerable people to the streets.
Right.
So I think we're beginning to think about the social determinants of health in a very different kind of way.
So, Elle, tell me, what do you think about how we start to change the narrative in communities that are not communities of color? How do we get the community broadly to appreciate these systemic structures and to recognize that this is why things are the way they are?
Right.
When I think about, the folks who stormed the Capitol on January 6th, how do we get them to appreciate that there's a broad system that has been put in place that leads us to where we are today? I think we have to frame a new narrative across the nation, and we keep talking to the communities of color when there are a lot of other people who need to have this conversation.
It's said that if Martin Luther King had lived, that the next phase of work was really to help to really advance the understanding on the part of poor white people that their plight, while they were white, that they were just as vulnerable to this system, to institutions, institutional and systemic inequities. There are many groups that are trying to do just that right now. That's the hard work. And we began to unpack our own history. But when we also recognize that projects like, the 1619 Project has been under scrutiny, and people are really trying to rewrite history, right? It's really about the narrative. And you're right, there is a narrative in the US that is really, I think, a false narrative around, and people haven't come to grips around the enslavement of people. I even try to use and be intentional around the use of the term enslavement instead of saying slaves, because those are my ancestors. Recently, a friend of mine was doing some genealogical work on my family, discovered that my great-grandfather had been born in 1863. And so he was born in South Carolina, and one might assume that he was born, which is the next piece of work that we have to do, that he was born into slavery. But certainly my great-great-grandparents were born into enslavement in South Carolina. So I try to honor them by talking about their status in this country as
Yes.
enslaved people, not as slaves, as a commodity, as something that was just simply listed on a sheet of paper as property, similar to a cow or a pig or even a dog. So we have to be real and honest and transparent about the history of America. This is not about blaming people. That's why I like the term systemic or institutional work, because once we, like, it's not about how we treat each other. That's why I'm not really involved in kind of equity, diversity, inclusion work. I'm not involved in people working with people on that individual level. I'm really trying to focus on the systemic or institutional level, because it's the laws, the policies, and practices that have been put in place.
Yes.
When we think about redlining, that was a policy and a practice by banks.
Yes.
And then the federal government made decisions around who would get VA loans. There are a number of clips. So to your point, I went off there a little bit. People need to educate themselves. What I say to people, even in COVID-19, do your own internet searching, do your own homework. Go to the website of the African American History and Culture Museum in DC. Find out about a different story about America that you're not always getting in the mainstream media. So it's really important that people do their own education. I'm not accountable and I'm not responsible for that. And quite frankly, when I do that work, it is emotionally draining for me because it's re-traumatizing me. So people have to do their own homework and find out the truth about their communities. Find out the truth about Pittsburgh. Find out the truth about Pennsylvania. Find out the truth about America.
I agree wholeheartedly. And I'd spend a lot of time these days talking to people about just that. You know, I can frame the issues for you, but you're going to have to do your own research and educate yourself and visit a variety of sources so that you have an opportunity to really appreciate how this country was structured and how our communities got to be situated in the way that they are.
And that's why I think that the scholarship that I mentioned earlier, Paula, right? Yeah. Read the books. They're there, right? They're well documented, right? This is not just fake news.
No, not at all fake news. This is America.
This is America, right?
This is America. So what would you say to us, as you know, from your stance in CCPH, as we're training young scholars who, many are now really excited about, going out into the community and playing a role in changing the way that marginalized communities are being treated and redistributing those resources. What should we be saying to young scholars right now?
Do your homework and approach it with humility, right? Do your homework. Don't make any assumptions. And quite frankly, that's true even for scholars of color, for academics of color. Do your own homework. I'm actively engaged in my own reading. And over the past year, I just read and read and read because I'm trying to unpack my own history and my own family and all of that. And so do your homework and read. And I think when you do that and approach the work with some degree of humility and just acknowledge what you don't know, because we make a lot of assumptions, right? So in that slide around the iceberg, there are a lot of assumptions that we make about people because of what we've heard or because of how people present. Right. And we do that. I want to acknowledge that one of the questions in the chat box says, how can universities support a living wage in communities? Well, I think, first of all, universities need to acknowledge the truth about their own wage structure and about essential workers and about all of the demands that they place on their own employees. Paula, I actually envision a world where people who are working at the University of Pittsburgh will actually be able to attend school at the University of Pittsburgh for free, where their children might even have access to attending.
Used to be close to free. It was close.
Right. and how we can really support communities and we can lift up communities through scholarships, through endowments, and through other philanthropic gifts to lift up our communities. I think that that's what I'm challenging. And then for universities to have a commitment to the living wage. Recently, a colleague shared with me that in a setting in an academic institution, it was in the middle of COVID-19 that they realized that they had employees that were actually food insecure. And the head of that organization said they had no idea. They just made certain assumptions about the employees, that people, were okay. And it just was not the case, right?
Yes.
And so we have to ask ourselves just that. And it might mean that administration takes the time and look at who rides the bus to work, right? How are people getting to work? And are people eating? To the credit of the Robert Wood Johnson Foundation, I want to lift up a tangible example. The first time I visited their campus in Princeton, New Jersey, one of the things they shared with me is that they have a cafeteria and all employees eat for free and they offer healthy foods. I thought, wow. And the reason why they did that, they said that they could not publicly advance a culture of health, and eating right is a part of culture of health, if employees didn't have access to healthy foods, or they had to pay for it. I thought that was really great. That was just amazing. I love visiting that campus all the time, and I get a free lunch, right? And so that's just an example of what I'm talking about, kind of rethinking
Yeah,
our institutions and our systems and kind of democratizing our work and looking at the inequities that are oftentimes baked into our system, and we're not even aware of it.
absolutely, absolutely. And I think that, one of the points that you made earlier in your presentation, how we value individuals and how we value communities makes, I think, a huge difference as well. Many times those individuals who are at the bottom rung, if you will, within our institutions are really just barely getting by. And there's
Right.
a sense that, well, you have a job, and that should be, you got a job and benefits, job done.
Mhm.
And that's not the case. That is not the case. Families need a lot more than that in order to be whole and to be healthy and to be successful.
Yes, absolutely. It's the people in the basement. It's what one of my family members says, is that it's the people in the basement, that the boiler room. It's the people that are cleaning the beds in our hospitals, right? It's the security guards that are walking and keeping us secure. Just taking the time out to talk to them and about how much are you paid. I think some people would be amazed at how little some people are paid. And also think about, how do you live in some of these urban centers for less than a living wage is just amazing,
Yeah,
right? And the fact that people leave their full-time job to go to another full-time job, or at the very least a part-time job,
yeah,
right? People may work from 7 to 3, 8 to 5 in one place, and then they leave and go 6 to 9 and clean up an office building. I did that as a young college student. I did that in high school.
hmm,
And one in closing, I think I will say to people that there are a couple of things that helped me out, and I just want to lift this up. And that is, first of all, I did receive free and reduced lunch, right? I also went to college at a time when there was amazing opportunities for lower income students to attend college. I left college in 1981 with probably owing $1,200.
okay, yeah,
Amazing, right? I mean, that's unimaginable today. But education was free. And the third thing that really lifted me and my family out of poverty was the fact that I had a summer job that was offered through a program called the CETA, Comprehensive Educational Training
hmm,
Act.
I remember
So
that.
we need to go back to the future and learn the lessons, how we lift people up. So that CETA program actually lifted me up. It allowed me to work during the summer to earn money to then go to college, right? So it wasn't a handout. I was working, and it lifted my sister and I have a twin sister, and both of us worked. And in fact, we worked a seated job during the daytime, and we left that job and actually went and cleaned an office building in the evening.
Yeah, absolutely. Yeah, there are definitely some lessons that we can take from the past, so we can reposition ourselves to move forward. Al, I want to thank you for your time and your expertise. And this has really been a wonderful conversation. And I think it gives all of us an opportunity to think more carefully about how we approach communities from the campus standpoint, and the ways that we can just do a better job for everyone in terms of our community engagement. So thank you so much for your time and your expertise.
Thank you. I put my contact information in the chat box. I would love to hear from people. It's al.richmond@ccphealth.org.
Wonderful. Thank you so much.
Thank you.